Injuries to the head range from minor scalp lacerations to traumatic brain injuries, which have the potential to be fatal or life-altering, as non-fatal head injuries can cause lifelong physical or psychological deficits. It is important as an emergency care provider to quickly identify the injury and provide the appropriate treatment. Scalp injuries. The scalp is the layer of tissue that covers the skull. The scalp is very vascular and tends to bleed profusely when injured. While a superficial injury to the scalp may only affect soft tissue, be aware that the mechanism of injury could cause injury to the neck or spine and may warrant C-spine and other immobilization precautions. If an open injury such as a laceration is present, apply pressure to the wound and dress with a bandage. If any crepitus is felt, you may assume a more severe injury and apply a loose dressing. Finally, assess the patient's mental status. Skull injuries. Skull injuries occur when there is a fracture to either the cranium or facial bones. It takes great force to fracture the skull bone, and these injuries tend to be severe. Skull injuries are classified as either open or closed. Face and jaw injuries. Facial fractures are usually secondary to trauma, which, if severe, may also cause brain injury. Some facial injuries have common signs. For example, if the mandible is dislocated or fractured, the patient may have difficulty speaking. When you encounter a facial injury, it is very important for you to check the airway for and remove blood, dislodged teeth, or bone fragments that may be causing airway obstruction. Brain injuries. Brain injuries are classified as direct or indirect. A direct brain injury can be caused by an object such as a bullet or a knife penetrating through the skin and skull directly into the brain tissue. Broken bone fragments can also cause brain injury. Closed brain injuries are injuries to the brain where the cranium remains intact. Blunt force trauma is a common cause of closed brain injuries. Traumatic brain injuries, or TBI. TBIs are an injury to the brain that interrupts its normal function. There are a few ways in which a person can incur a traumatic brain injury. They include concussion, contusion, laceration, hematoma, or increased intracranial pressure. Concussions are injuries to the brain sustained by blunt force trauma, such as a fall or a blow to the head. They range in severity from the patient's unawareness that they have sustained an injury to a brief loss of consciousness. Concussion symptoms can include grogginess, headache, or some mild form of memory loss. A brain contusion occurs when blood vessels in the brain rupture. This is often caused by a coup injury in which a force strikes the head abruptly, forcing the brain to strike against the inside of the skull. When the resultant force causes the brain to strike the opposite side of the skull, it is referred to as a contra-coup injury. Contra-coup injuries occur when the brain strikes both sides of the skull. This type of injury is common in many automobile accidents. A laceration of the brain can occur if the brain is injured by the interior of the skull, which has many sharp, jagged ridges. A hematoma is a collection of blood that can be caused by both blunt and penetrating trauma. Hematomas can cause pressure inside the skull to increase, raising the intracranial pressure. If the bleeding occurs between the dura mater and the brain, it is referred to as a subdural hematoma. If the bleeding occurs between the dura and the skull, it is known as an epidural hematoma. An intracerebral hematoma occurs when blood accumulates within the brain. Any type of bleeding or swelling within the skull increases the pressure as the skull is rigid and has little capacity to expand. As the pressure builds and the brain is compressed, blood pressure also increases to try to force blood into the oxygen-deprived brain. As the swelling increases, more of the brain tissue is forced through the foramen magnum. This is known as brain herniation. Other signs and symptoms of increased intracranial pressure and herniation include abnormal posturing of the patient in either a decorticate or decerebrate position. The rate at which these symptoms develop may correlate to the origin of the bleeding. A subdural bleed is often slow, and symptoms may take a few days to develop. However, symptoms of an epidural bleed often appear rapidly, causing ominous signs of increased intracranial pressure. Signs and symptoms. The most important task is to be able to identify a brain injury. General signs and symptoms include confusion or altered mental status, pain, obvious trauma in the form of battle sign or raccoon eyes, unequal pupils, clear fluid discharge from the nose or ears, Cushing's reflex, which is increased blood pressure and decreased pulse rate, seizures, posturing, impaired vision, and paralysis. Assessment. Next, check the patency of the airway and assess the quality of the patient's breathing. Continue your primary assessment, identifying and treating any life-threatening conditions. Patient care. When a head injury is present, always assume a potential spinal injury is present and immobilize the patient with a cervical collar and backboard. Assess the airway and assist with ventilations using a jaw thrust maneuver to open the airway. Administer high concentration oxygen. Some protocols call for hyperventilating a patient with increased intracranial pressure by ventilating the patient with oxygen at a rate of 20 breaths per minute. Control any bleeding. If a discharge is noted, do not attempt to occlude the discharge as it may increase intracranial pressure. Continue to monitor and transport the patient immediately. If there is an impaled object, do not remove it. Secure it in place with a bulky dressing. If the impaled object is too large to transport the patient, reduce the size of the object with the assistance of the fire department. Glasgow Coma Score. All patients with head injuries must have their mentation assessed. A simple AVPU or APFU should be used at first in order to not delay transport. En route, a Glasgow Coma Score should be obtained. This score rates the patient on a scale of 3 to 15 using eyes, verbal response, and motor response to gauge the patient's mental status.